you, Amit. This was a very interesting discussion. Brought out some of the very important considerations in treating one of the deadliest cancers, pancreatic cancer, which has failed to show improvement in survival despite some of the best research in NIH on this, on pancreatic adenocarcinoma. So obviously, there are many ways that medical oncologists are trying to change their algorithms and to change their treatment sequencing so that some improvement in survival may be achieved. Some key conclusions from all this discussion is, and particularly for people who are, who are learning how to deal with this difficult disease, resectable pancreatic cancer still remains a surgical disease for the simple reason that a patient who has come to you in a curative stage of pancreatic cancer should not be subjected to upfront chemoradiation because a certain proportion of those patients will progress while on neoadjuvant therapy. And then the window for giving a curable patient a cure would be lost, which is highly unethical. So upfront surgery is still the recommended guideline for patients who are curable outside of a clinical trial. Let there be no doubts about that. The role of neoadjuvant chemoradiation is well recognized when it comes to borderline resectable or locally advanced pancreatic cancer. And I think the guidelines for that have been very well elucidated here. As far as the surgical technique goes, pancreaticojejunostomy is generally a favored technique. It's a end-to-end or end-to-side duct to mucosa anastomosis. And then otherwise it remains a personal preference and the training preference of the operating surgeon. So thank you very much for this very interesting discussion. Dr. Kantharia, thank you particularly to you. Those are very good papers and very interesting papers. And all the panelists who highlighted the important issues which face surgeons in treating this difficult disease. Thank you.